Good morning and welcome. I have the honor to introduce our first speaker this morning. Not only is he known for his authorship of countless scientific papers and textbooks of anatomy, neurology, and embryology, but he has been awarded many accolades such as the Norton Distinguished Teacher Award 4 times, the Robert W. Kirk Award by the ACVIM, and the Cornell Alumni Association Salmon Award for Distinguished Alumni Service. He is legendary for his 2 a.m. neurology rounds, but what you may not know is that you could also find him pushing pro sections at 1:30 in the morning down the hall, and he could be found running 6 miles through the Arboretum in the early afternoon. Every Friday lunch hour was packed with first through fourth year students for his review of the neurology cases of the week. And he gave every Cornell veterinary student at least 3 oral exams that I can vividly remember 12 plus years later in applied anatomy and neurohistology. He exemplified the essence of the Norton Distinguished Teacher Award. He excited his students and made them want to learn. So without further delay, I would like to please welcome, out of retirement, Dr. Alexander de Lahunta. And feel free to leave. There will actually not be a break in between the 2-hour session, so if you need to get up, he said to just go ahead. Welcome.
Thanks very much, Ashley. I appreciate that. I have a lot of cases to go over with you. My format is to present you with a patient to make the anatomic diagnosis. That is absolutely crucial in any clinical neurology situation, is making the accurate anatomic diagnosis. So I'd hope to review as much as I can about that. This will be limited to spinal cord and nerves and the end of the 2-hour session. I'm required to tell you that I have no disclosures. All of the videos that I'm going to show you are in the website available to anybody at no cost, sponsored by Cornell University. These cases are all discussed in depth in the 3rd edition of my textbook. The website will provide you with a signalement. You can look at the video, then you can click on what I think the anatomic diagnosis is, and then you can click on what I think the clinical diagnosis is, but the discussion of the basis for that is in the textbook. And just to very quickly review what I mean by anatomic diagnosis, there are 6 or 7 regions we dwell on. Certainly the prosencephalon, we don't worry about which gyrus that we're talking about here. We're worried about the prosencephalon. Then we're worried about the cerebellum, the brainstem, particularly the caudal part of that brainstem. And to be sure everybody's accurate here, the brainstem starts with the diencephalon, includes mesencephalon, pons, and medulla. I've recently reviewed a book in which the brainstem is only the pons and medulla, and that's nonsense. You've got a brainstem here with 2 cerebral hemispheres and a cerebellum stuck on top of it. You have the cranial nerves that come off that brainstem that provide anatomic diagnoses. In the spinal cord, you've got 4 major regions of that spinal cord to make an anatomic diagnosis. And in particular, the neuromuscular system, starting with the cell body in the ventral great column, out in the roots through the various nerve branches, and out here to the neuromuscular junctions. A disease of any part of that component will have the same characteristic clinical signs. We'll start with Oslo, a 6-year-old female Dutch warm blood. 7 months of progressive pelvic limb gait abnormality. And I had to put this on here. I'm sorry, but I'm not a believer in all of these alternative medications before you've made an appropriate anatomic diagnosis. But all of this stuff that's been done in this poor horse, the only thing that suffered is the horse. All right, so let's look at this patient. I will tell you that cranial nerves are all normal. All I'm concerned about is the gait. you should appreciate that there's a bit of a delay in the onset of protraction, that's the swing phase, and then many times that swing phase is a little bit longer than it should be. It's easier to see this in thoracic limbs than in the pelvic limbs, but it's present in all four limbs. And then you ask, upper motor neuron, general proprioception, which is which? I can't tell them apart, and I don't ever worry about it. You don't need to tell the difference between general proprioceptive ataxia and upper motor neuron paresis. What this is telling you is that both systems are affected somewhere in front of the cervical intumescence, anywhere from the C5 or C6 segment up into the brainstem. And without any other signs relative to the brainstem, you're somewhere in that cervical spinal cord between C1 and C5. To me, this is the classical appearance of a horse with either a focal or diffuse lesion between the first and fifth cervical spinal cord segment. So that's our anatomic diagnosis. And don't forget, it can be either focal or diffuse. You can't tell the difference on what you just saw in that MRI. The white matter tracts that are showing you these clinical signs are upper motor neuron and general proprioception. And here's the point that I'm trying to make is these pathways are right adjacent to each other. And we're not trying to dissect what part of that spinal cord is being affected. We want to know what segments of the spinal cord are involved. And yet everybody talks about, oh, my horse has got an ataxia. He's not going to have that ataxia without a degree of paresis at the same time. So the differential diagnosis, cervical vertebral stenosis, there are all sorts of terminologies for this, starting with the old age wobbler syndrome. In my opinion, I think that these are very much related to osteochondrosis in the rapidly growing horse. And this either ends up in a stenotic vertebral foramen with compression of the cord. It may be dynamic, it may be static. That's a radiologist's province to have to solve for you. Anytime you get a little bit of malarticulation, that's going to lead in time to degenerative joint disease. And in the horse, we're concerned about articular processes. In the dog, you add the intervertebral disc. But the intervertebral disc is not involved with this in the horse. So that, to me, is the most presumptive diagnosis in a horse of this age and with this chronicity of clinical signs. This could just as well be protozoal myelitis. It can be chronic like this. You like to have a little more asymmetry of protozoal disease, but that's still a consideration. Equine degenerative myeloencephalopathy, which now those folks on the West Coast are trying to call this neuroaxonal dystrophy. I'm not totally convinced that's appropriate. There's no question there's an axonopathy of the tracts in the spinal cord, upper motor neuron, and general proprioception. And yes, there are spheroids in many selected nuclei in the caudal brainstem and in some portions of the spinal cord, but I think that's saying too much to make this just a neuroaxonal dystrophy. That's nothing for you to worry about at this point. This horse is much too old for that. That's a problem that begins in a youngster clearly under a year of age and is slowly progressive. Clinically, would look identical to what that horse looked like. And don't ever forget, they get cocky about this because these viral diseases, rabies or Eastern equine encephalomyelitis or West Nile disease, may present initially with clinical signs just like that. Now, they're not going to last there the number of weeks it has for this horse, but don't exclude them. There's a radiograph that shows degenerative joint disease involving the articular processes at C6, 7 in this horse. And now, a horse could just as well have that and absolutely no compression in the spinal cord. You'd need a myelogram, or in this day and age, if you have the facilities, a CT or an MRI, particularly the latter, to show the spinal cord compression. This horse was necropsied, and you're looking at the cranial aspect of C7, and look at the asymmetry between the articular process on either side, the slight narrowing here, You can't, it's a little hard to appreciate, but that joint capsule is extremely enlarged. And that's what it's articulating with. This is the caudal part of C6, and you can see how large that articular process is. Sometimes you get synovial cysts involving the synovial joint there that add to the compression in these cases. Now I want you to compare this horse with a 9-year-old male thoroughbred, losing weight but eating well. Those two components there. Losing weight, eating well, be careful, this may be neurogenic atrophy. A horse can lose hundreds of pounds just from neurogenic atrophy. For 1 week, this animal exhibits tremors, sweating, a shifting weight, and excessive recumbency. Notice this horse stands here, he keeps stepping from one limb to another, very typical of this particular anatomic diagnosis. This horse is stressed out a bit, and so is sweating, and you can see the fasciculations of the limb muscles. All of these are characteristic features of a lower motor neuron disorder. They would much rather walk than stand. And if you leave them, if you put them back in the stall, very quickly many of these horses will just immediately lie down. They do not like to support weight. And that's very typical of lower motor neuron disease. Look at the stride of this horse compared to what you just saw. These are short strides. The gait may look normal to slightly short-strided. There's absolutely no loss of knowledge of where those limbs are in space. Head and neck down a bit. When you make him turn the circle. Now this horse isn't going to move very fast, but what the movements he has are perfectly normal. Maybe they're a little shorter than normal, but there's no floating, no tendency to bring one forelimb over the other, no delay in the onset of lifting a pelvic limb off the ground. These are the characteristic features of an animal with a lower motor neuron or neuromuscular disease, and this is very typical of equine motor neuron disease. This animal could have his lesion anywhere from the cell body in the ventral gray column of the spinal cord all the way out to the neuromuscular junction, and he could walk the same way. In this particular disease, the problem is entirely located up here in the cell body in the ventral gray column. There's a normal alpha motor neuron right there, and this is one that's undergoing distension as in its early stages of degeneration. There's one that's swollen there, chromatolytic. Here's one that's being digested. It's dying off, and it's attracting macrophages and glial cells. In the end stages of this, you're going to have absolutely no evidence of the cell body being there, and you're going to see a little bit of lipofuscin accumulate there. These are the scars that are left over where that neuron has degenerated. The interesting thing is that same accumulation of lipopigment, it'll occur in the endothelial cells of the blood vessels in the spinal cord and brain. It also occurs in the retina. Now, the vitreous should be up here. That's the inside. The outside's down here. This is actually the tapetal layer of the choroid. That's the pigment epithelium of the retina with too much pigment in it. And that's this is the outer nuclear layer. The layer of rods and cones are degenerated, and all that lipopigment is infiltrating through there, and eventually it'll destroy the entire nervous coat of the retina right there. This is pigment epithelium here. And we have not recognized clinical evidence of any visual deficit in these horses, but a real sharp ophthalmologist at time can, if there's enough of this accumulated, can pick that up on ophthalmoscopic examination. This is a standing horse with this particular problem. From a diagnostic point of view, there's two features to consider. One is you can take a muscle biopsy of the sacrocaudal dorsal medial muscle, which is high in the postural muscles, the type 1 muscles that are particularly affected by this particular disorder. Or you can come up here, and here's your sternocephalocus muscle coming up here, and there's a branch of the accessory nerve that enters it right there. You can take a fascicular biopsy of that and get a histopathologic section. There's degeneration right there. There's some degeneration down here. These are normal fibers in here. and there's a higher power. And you're looking at Wallerian degeneration here because the cell body way up in the ventral great column of the cervical spinal cord, where the accessory nerve comes from, those cell bodies have died off. And you're seeing the evidence out here. But that's a nice clinical diagnostic tool for this particular disorder. So this is a degeneration of neurons that innervate type 1 postural muscles. These are the ones that are highly oxidative in their metabolic activity. And this is an oxidative stress from deficiency of vitamin E and or superoxide dismutase 1. That's an enzyme that converts the oxygen radical, which is very toxic to cells, to H2O2 and oxygen. We believe in the horse that this is a secondary effect, and the reason that the superoxide dismutase is decreased in quantity is because it's being used up by that cell, because the primary problem is your vitamin E is deficient in these animals. It takes about 30% loss of neurons before you get clinical signs present, and then they usually present fairly rapidly. To a degree, this is an animal model for amyotrophic lateral sclerosis. The disease is known as Lou Gehrig's disease. There is no lateral sclerosis in the horse. This primarily affects the corticospinal tracts, and of course the horse has a very poorly developed corticospinal tract. In humans, there's a familial form, which is a genetic disorder, the mutation of the SOD1 gene, and the sporadic form, which is much more common, which is really not clearly delineated on a pathogenetic basis, but may well is considered to be some kind of a failure of the superoxide dismutase 1. These people are not vitamin E deficient. It takes a little more than 14 months of deficiency of vitamin E to produce this particular disorder in the horse. And to show you an example of that, Tekka is a 15-year-old female thoroughbred suffering from weight loss, eating well, but undergoing denervation atrophy, has the same shifting weight, short-strided gait, and prefers to lie recumbent. As the horse is there, not too many times do you walk out in the stall in the morning and see a horse laying out like that can still get up. When the horse comes up in the sternal, usually sits there with its chin resting on the ground. When it stands up, it'll tremble. It'll shift its weight continually. And as soon as it gets enough to eat, it's going to turn right around and lie back down again. The equine industry knows enough about this disorder now that vitamin E is pretty much included in all the dietary supplementation of horses. So the incidence of this disease has dropped off dramatically. But there's a horse with a disorder produced by a diet deficient in vitamin E. HEM is a 2-month-old female Holstein. Abnormal gait, slowly progressive for 2 weeks. Now think what you just saw in those two horses and make this anatomic diagnosis. At 2 o'clock in the morning in the large animal clinic, there's nobody there to bother you. As this calf turns, watch very carefully on the outside limb. And watch it just float a little bit, overreach a little bit. Oh, there it is. You think about how a calf normally walks. I hope I can convince you that this calf is walking more like the first horse you saw, Oslo. Now, I'm not capable of doing this for a horse the size of Oslo. Some neurologists will pick up one limb at a time and with their shoulder push him to the side. I never felt I could use that successfully. But in a guy this size, and a calf as cooperative as this one is, and there may be a good reason for that I wasn't thinking of at the time. But to me, these hopping responses are slow. It takes both normal UMN and GP systems for the hopping responses to be normal. There's no way you can test for general proprioception by itself, regardless of what people teach you or is in the literature. That's my humble opinion. So what do you think? Do you think this looks like a lesion between C1 and C5, or a lesion in its neuromuscular system? You wouldn't answer me anyway. I think this is an absolutely classic gait for a calf with a C1 to C5 lesion. Very cooperative calf. Thank you, sir. So that's my anatomic diagnosis. What's your differential diagnosis? This has been a couple of weeks of these signs slowly progressing, and I thought this is going to be discospondylitis or vertebral canal abscess to proven otherwise. And I could include in that differential lymphosarcoma. At this age, that's very uncommon. You know, the bovine leukemia virus creates it in animals 3 or 4 years or older, but it can rarely occur in the young one. Now, why would I put hepatic encephalomyelopathy on it? Well, because that's what it was. You're learning from the way I learned, okay? We radiographed this calf, saw no evidence of any osteomyelitis or anything associated with discospondylitis, and they put the calf down. And this calf had the most profound polymicrocavitation throughout its white matter, and including brain as well as spinal cord. There are 2 histopathologic lesions as seen with hepatic encephalopathy. The Alzheimer type 2 cells, which are astrocytes with very large nuclei, and they're overworking because of the necessity to metabolize ammonium, all right? And the other lesion is a polymicrocavitation. That polymicrocavitation does not occur in the horse. It occurs quite profoundly in the ruminant, and it can occur profoundly enough to interfere with function, and that's exactly what it was doing in this calf. And the interesting thing is this calf had a portosystemic shunt. I believe it was an extrahepatic shunt, and when, we say, how the hell did we miss that, Well, who would thought to do blood ammonias on a calf walking like that, unless this was in your differential diagnosis? And when we went back and looked at the data, there were some little subtleties in the biochemistry that was done in this calf that said, yeah, you really should pursue the Livermore comment. So now I failed, you're going to learn. You've learned. Okay. MG, 1-week-old female Holstein. Since birth, less active, short-strided, often recumbent. Now think of the calf you just saw. I can't get a better contrast for you. Look at him shift his weight back and forth. Head and neck down. Little short stride, trembling. She also wants to urinate. It's very difficult for her to get in a posture to urinate. Get the tail up, but that's about it. And she wants to lie down. And she's getting a little weight off her abdomen right now. Gonna make it, oh, yeah. It's a long ways down. Doesn't that feel good? Classic diffuse neuromuscular disease. Can't get any more classic. And so when you consider where we're going to put this lesion, we have to think of that cell body. There's a autosomal recessive disease in it's coming to me, I'll put it right here, in the brown Swiss calves. Large numbers of these have been described by Leipold in Kansas. And certainly these calves would look exactly like this one did at this particular age. I've never seen polyradicularitis in a calf. Never made that diagnosis in a larger ruminant species. A myasthenic syndrome has been described in Brahman calves, and this is a autosomal recessive disease for which there's a PCR test in which you can detect the heterozygotes. So considering these diseases, let's see if we can help this calf out. Let's give this calf some tensilon. Got some help to kind of urge it along. The troops are coming. Uh-oh. That looks like trouble to me. Do you think that calf's improved? Wait, look at that, look at that, look at that. That's a new calf. See, that's good stuff. I want more of that. Yeah. I don't know whether Tom Divers put this calf on a physostigmine for a period of time, but this calf slowly grew out of this problem. And some of your congenital myasthenics in dogs, in puppies, some forms of that they will grow out of. It all depends upon how abnormal the neuromuscular receptors are on those muscles at that time. 3-month-old female Toggenburg, 3 days of progressive gait disorder. I think you ought to recognize there's a difference between the right and left sides in that kid. This is a right side upper motor neuron general proprioceptive problem. So you got a C1 to C5 focal or diffuse lesion in the white matter tracts on the right side. And this is a 4-month-old kid. And certainly any kid under 6 months of age has to be consideration for CAE viral myelitis. My astute colleague at Cornell, Mary Smith, who to me is the guru of any of these small ruminant problems, tells me that this disease is quite rare now, and there is some concern that maybe the virus has changed a little bit, so it no longer produces the degree of neurologic disorders it used to. Still produces mastitis, pneumonia, and arthritis in older goats, but the neurologic form was a young form. So I don't know how common this was, but for a while it was very common at Cornell and could produce bilateral or unilateral clinical signs. Discal spondylitis is much less likely to be as asymmetric as this. Vertebral corneal abscess the same way. There certainly could be P.TENUIS myiasis. It might take, and experimentally, I've read you can actually produce lesions in 11 days if you really dose the ruminant species with a huge dose of the larvae of this organism. So it'd be unlikely in an animal as young as this, but a possibility. Enzoitic ataxia would fit 2 to 4 months of age, but the asymmetry would not fit. That's a disorder that produces bilateral axonopathy in the spinal cord and degeneration of cell bodies in the ventral gray column. So you can get combinations of UMNGP signs and lower motor neuron signs. Was not a very common occurrence in my experience. If we look at these spinal cord sections from a goat with signs like you saw, look at this section right here, and look how swollen that side is. And to show you what that looks like, look at the inflammation. It's all on that one side of the spinal cord. And this is the CAE lesion. Look at the inflammatory cells, just massive accumulation of inflammatory cells. All of these are mononucleotide cells, many plasma cells, and many macrophages. And some of these macrophages are quite bizarre. And that is the basis for calling this a granulomatous lesion. The fact that it has such a huge accumulation of macrophages and these multinucleated ones. The virus actually is in those macrophages. And the interesting thing is that the initial lesion that occurs in this disease is a demyelination of axons. And I've got this right here. Look at these axons streaming through here. And look at the macrophages here, just stripping the myelin right off of that axon. But the immune system reacts. And this is a cell-mediated immune response. And that's why there's such a huge accumulation of inflammatory cells that follows that initial demyelination phase. 6-month-old male thoroughbred, found at pasture, unable to walk with its left thoracic limb. This is not a difficult anatomic diagnosis. It's pretty obvious that this young horse cannot support weight in the left thoracic limb. The question is, can he not support weight because the extensor muscles are denervated, or does he not support weight because he got a fracture of his elbow or a fracture of his humerus? And if you saw this colt come off the truck, you know that this colt is not suffering. And you certainly can palpate and look for swelling if you're worried about this being an injury of any sort. And you're looking at a horse that has the typical signs of a radial nerve paralysis. Now, there may be some paralysis of other muscles in there, but there's no way you can tell by watching the gait of the animal. You're seeing the effects of a radial nerve paralysis. So this is a brachial plexus or radial nerve injury. I don't know what the incidence is, but I've read somewhere way back that about 50% of these horses will respond spontaneously and about 50% will not. I've never had a chance to dissect one of these to find out how diffuse the lesion is. Nobody has ever described an avulsion of the roots of the brachial plexus the way that occurs in dogs and cats. And this particular horse made a complete recovery. Now, compare that with STARLANE. 16-year-old male Clydesdale, 4 weeks of progressive lameness in the right thoracic limb. And all of his orthopedic studies that were done up to this particular time have been normal. Now it's not hard to tell that he's lame in the right fore. And is he lame because he's in discomfort? Or is he lame like this because he's having difficulty supporting weight? And don't forget, any animal, I don't care what species it is, if it walks lame, there's 2 reasons for that. He got a stone in his shoe, and he hurts, or he's got a neurologic problem in his anti-gravity muscles. Now, it's not too hard to tell that this stallion is not suffering much pain. And he certainly exhibits lameness in the right thoracic limb. And it's very appropriate that this horse had had a thorough orthopedic study prior to being referred to us for further contemplation. Notice that his ears are very erect. When you look more closely at the horse, a suspicion there might be a little atrophy in the proximal thoracic limb muscles. Now watch the face of this horse. Watch the nose. Ha-ha, deviated to his left, and the lower lip was drooping a little bit, but the ears are fine. That means he's got something wrong with his right-sided buccal nerves, buccal branches. So the anatomic diagnosis is radial nerve, or the segments of spinal cord that it comes from, or the roots, or the spinal nerves that connect the spinal cord with the radial nerve. And the right buccal branches are severed. Maybe he got injured there. And may have absolutely nothing to do with this particular problem. Certainly any asymmetric spinal cord lesion has to be a consideration for equine protozoal myelitis, and maybe there's a little brainstem lesion in the right facial nucleus that only affected buccal nerves. That would be kind of unusual, but I couldn't rule it out. What can affect nerves, spinal nerves, as well as cranial nerves? Polyneuritis equi can. And it doesn't always stay in the cauda equina. So that has to be on there. I remember standing beside this horse with Tom Divers and saying, hey, Tom, if that was a 16-year-old dog walking like that, this is a nerve sheath neoplasm until proven otherwise. He said, okay, that's fine. What's the horse got? Well, we put the horse down, and when I dissected the roots of the cervical intumescence on that side, you're looking at the 8th ventral branch of the 8th cervical spinal nerve, headed right for the brachial plexus. It's larger than normal, much firmer than normal. And if we look at that, did I miss something? That's a piece of that histologic section of that. These are nerve fascicles in here. The epineurium is out here, and you can see all the cells that have accumulated in there. These are all lymphocytes. You're looking at lymphoma. Between the epineurium and the perineurium and within the fascicle itself. All right, these are axons and myelin, but all surrounded by the neoplastic lymphocytes. So this was a nerve neoplasm, but it's intraneural lymphoma in that horse. And the same lesion was in the buccal branches of the right facial nerve. So they were the same thing. Now you got to look carefully in this horse. I'll clue you right now. Well, you just read the histories. 14-month-old male thoroughbred, 11 days, sudden onset of lameness in the right thoracic limb. They thought that was an injury of some sort, but the signs progressed. And 4 days before he came in the hospital, the right pelvic limb was abnormal. Watch carefully the right limbs. And there's quite a bit of tape here, so you've got plenty of opportunity to watch. Watch the right thoracic limb to begin with. Watch the way he tends to buckle on it and then flip it forward to come down on the palmar surface. You're never going to see a horse with a C1 to C5 lesion walking like that. And I can tell you, as I circle this horse towards his right, when I'm on his right side, I'm giving this horse plenty of room because I'm a little worried that he might fall into me. I think you're looking at a partial radial nerve problem in that right thoracic limb. Now watch his right pelvic limb. Watch him pivot on it. He supports weight fine in that right pelvic limb, but he's having difficulty using it. He shouldn't pivot like that on it. I'm trying to convince you that you're looking at some lower motor neuron signs in the right thoracic limb and upper motor neuron general proprioceptive signs in the right pelvic limb. And this is a good example. If you want to study this one further, go on the website. It's all on there. So right side, C6 to T2 spinal cord segments. To me, that's the anatomic diagnosis would explain these signs. The asymmetry, relatively young horse, the progression, fairly rapid progression, is absolutely a classic feature of equine protozoal myelitis. That degree of asymmetry I've never seen with a cervical stenotic myelopathy. Equine herpes virus myelopathy, I've not seen it asymmetric like that, and that's a sudden onset. It's going to peak with its signs within 24 to 48 hours as a rule. Abscess, neoplasia, they could be on one side of the spinal cord, but they're rare in the horse, and I'll show you P.TENUIS in the horse in a moment. Very unusual to produce signs like that. And all I have for you here is just a gross lesion. There's a cervical spinal cord segment. And look at this lesion right here. The gray matter lesion accounts for the right thoracic limb lower motor neuron. The white matter lesion out here accounts for the right pelvic limb UMN GP deficit, and that's equine protozoal myelitis. 4-month-old mixed breed lamb, unable to stand. 3 days of progressive difficulty walking. Mary Smith knew that I put on rounds, clinical rounds, on Fridays. And for a while, when I had plenty of patients available, I did it in a large animal clinic. And I'd come out to do my rounds at 12 o'clock, and there'd be a bucket on the floor. And I'd know that when I looked in that bucket, there'd be a lamb. This is a Mary drop-off. Mary Smith drop-off. And she knew that I would show this lamb at rounds, and then I would help do the necropsy that afternoon. Tetraplegia. Quality of the paralysis. Well, he's not walking. What can I look at? All you can assess is tone. Picking him up and down like that, good tone in those pelvic limbs. That makes me think upper motor neuron. Good tone. Thoracic limbs, little tone. Very little tone. And to go along with the hypertonia, there's a good reflex. Get him relaxed enough. Good patellar reflexes. Withdrawal reflex, very good, along with positive nociception. Thoracic limb, less reflex, I can feel it's less. Little less response. So I've got lower motor neuron signs in the thoracic limbs. I've got upper motor neuron signs in the pelvic limbs. All the basis for this tetraplegia. My anatomic diagnosis is C6 to T2 spinal cord segments. Discospondylitis has to be high on your list. We've got a short period of progressive signs or a vertebral canal abscess. P.TENUIS is a possibility. This lamb is on the young side for that particular disorder. Listeria myelitis. Why did I put that in there? Because I've been faked out on one sheep with severe myelitis due to listeriosis. Almost all of my experience with listeriosis has been brainstem intracranial disease. But listerial myelitis is seen quite commonly in Australia and New Zealand. And I've seen it once in New York State, so I don't leave it off. Enzootic ataxia would not produce the difference between lower motor neuron signs, thoracic limbs, upper motor neuron signs, pelvic limbs. such a severe tetraplegia in such a short period of time. So discal spondylitis has to be high on the list. If you look carefully, watch right in here. Yeah. That's between C5 and C6. You can see the lysis that occurs into the vertebral bodies on either side, and that's discal spondylitis, the basis for the tetraplegia, and you're down right under the cervical intumescence, which accounts for the anatomic diagnosis. This is a very interesting experience. This is my first experience with this particular disorder in a live animal. It's a 2.5-year-old mixed breed horse, abnormal gait for 5 days, and the owner's complaint of a swollen neck for 2 days. Now, the scoliosis is obvious, and I cannot bend that neck to the animal's right side. Now, just forget the scoliosis a minute and watch his limbs very carefully and see if I can convince you that it's a very, very slight abnormality in the right limbs. Watch that right thoracic limb, especially when I turn him in a circle to his left. Right there. Right there. He overreaches, swings a little bit wide. Much easier to see in the right thoracic limb than the right pelvic. And very mild signs. Now, poor old Thor, he'd been in the hospital for a while, and everybody and their brother had been pinching him with forceps. So he's getting a little upset with this, so you have to be a little patient here. But there's absolutely no response from about C3 to C7. No response under that bandage. As soon as I get in front of that bandage, he says, enough of that stuff. He's analgesic from C3 to C7. Not on this side. I'm actually going to clip the forceps onto the skin and leave them there. And I took them off. That's analgesic. Okay, so what's my anatomic diagnosis? Right side, C3 to C7 spinal cord segments. A dorsal gray column lesion certainly would account for the lack of nociception on the right side, where the afferents come in to synapse on the projection pathways up to the brainstem. How are you going to explain the scoliosis to the left? Well, if you had a ventral gray column lesion on the right and denervated the muscles on the right, then the unopposed lateral muscles on the left would pull the neck around to that side. But there are no lesions in the ventral gray column in this guy. If I interfere with the neuromuscular spindle activity, where the 1A afferents are coming in to the dorsal gray column, wipe them out there. Those 1A afferents are terminating on ventral gray column alpha motor neurons that are going out to maintain tone in that muscle on the right side. If I take that away, I've lost the tone on that side, and the neck is going to deviate around. And based on the anatomic location of the lesion, that's where the problem is occurring in this horse. If my lesion in the ventral gray column kind of sneaks out into the lateral funiculus a little bit, it's going to pick up UMN and GP tracks and account for that little bit of gait deficit that animal has on the right side. My first experience with this was when one of our industrious students went to an equine practice in New Jersey and brought back to me a videotape of a horse that looked exactly like that and a vertebral column bent around like that, which I took the spinal cord out of and found glorious lesions in the dorsal gray column. Just lesions, inflammation, destruction, nothing else. And we got some slides sent to us from Ohio State on a horse with the same clinical complaint, same dorsal gray column lesion. This horse came into the clinic, clinically exactly like the horse you just saw. And in the spinal cord, if you look here, look at the lesion up in the area of the dorsal gray column. Take a longitudinal section through there, see it? Now I'll make that histologic. There's a tract lesion of destruction and inflammation. Dorsal gray column is right here. And the higher part of that, there they are. And let me tell you, after you've spent a lot of time looking through all these damn segments, and you see something like that, they could hear me a half mile away at my microscope when I saw those damn things. And we got Mike Duffy is a parasitologist that was at the Virus Research Lab, and he identified the family as Protostrongyllidae, and that's the family that includes Paralaphistrongius tenuis. So that's the presumptive basis for this particular organism. And so if we put our lesion right here, I'm going to get analgesia from the nociceptive fibers that are coming in here. I'm going to get the loss of tone in muscles on that side by involving the 1A afferents, and the unopposed tone on this side is going to cause the scoliosis. This P.TENUIS, I mean, this is a rare problem in the horse. Maybe it's more common than we know about now that we're aware of it, but anyway, it's a rare common problem in the horse, but it's very common in the camelids and sheep and goats. It has also been reported in cattle. This is a meningeal worm of the white-tailed deer. The intimate host is a mollusk, a snail, or a slug of some sort. And just to remind you, the life cycle, this is the normal parasite relationship in the deer, the white-tailed deer. And so the deer is going to consume the mollusk, or more likely the slime that's in the browse from this particular mollusk, which contains a third-stage larva. Gets ingested. How it gets from the GI tract up into the vertebral column to invade the meninges is unknown. But it gets up there, and it migrates forward, and it migrates right along the dorsal root entry zone, which is kind of provocative when you think about the lesions we've just seen in the horse. It goes through another molt, and it becomes an adult up in the cranial cavity, and these are little thin, little hair-like strands that make up this adult. And it lays its eggs into the venous sinus. The eggs circulate to the heart, out to the lungs, become a first stage, they hatch into a first stage larva out in the lungs, and they get in the airway, they get coughed out, they go into feces, they get into feces, and the first stage larva look for the footpad of a mollusk or a snail, get in there, and the cycle continues. So the way to break this, obviously, is to keep the deer out, get a guard dog, or browse your sheep and llamas, etc., closer to the barn with space between them and the woods, or double fence the outside. And as Mary says, get guinea hens and ducks, because they'll eat the mollusks and the snails. There's a lot of data in the literature about using ivermectin to try to prevent this disease, is try to treat this disease. When I retired in 2005, I'd been exposed to 6 horses from 5 months to 3 years of age with this particular scoliosis and the ipsilateral, for the lesion, ipsilateral lesion, analgesia, upper motor neuron paresis, and GP ataxia, and scoliosis concavity, the opposite side. I think Cornell's got something like 11 cases now, and one of these in the thoracic vertebral column, causing a scoliosis there, but all the others have been up in the neck region. 2-month-old female mixed breed lamb, vaccinated along with a whole bunch of other lambs, tail docked at 2 weeks of age, and this lamb was unable to stand and walk since then. This is another Mary Smith drop-off. Bright alert responsive, normal cranial nerves. seems to want to use the thoracic limbs very well, seems to have difficulty using the pelvic limbs. Now, what I want you to appreciate here, you obviously can see the fact that the thoracic limbs look normal, and obviously the pelvic limbs are abnormal. There's good tone in those pelvic limbs. But notice the difficulty this lamb has in controlling its trunk. I've got to constantly hold on to the left side, or it'll sway off to the left side. Now, while you're watching this, let me add for my concern about the trunk. You know, we see a lot of lesions that are anywhere from T11 back to L4, and they give us typical spastic paraparesis and ataxia, okay? And they hold the trunk pretty well. But think of what's going to happen if I move my upper motor neuron lesion up to, say, around T3 in the craniothoracic region. That takes upper motor neuron away from all those axial muscles. They got nothing to do with the limbs, but they have got something to do with controlling that trunk. So when I see an animal that can't control its trunk well, then I worry about that upper motor neuron lesion being further up in the thoracic area. Not T1 and T2, because then I'd affect the cervical intumescence. But anywhere from T3 to, let's say, T5 or 6, I'm going to have difficulty with that trunk support. And I think this lamb is showing you a good example of that. Now, I'm not going to go through all the reflexes here. This animal's got good patellar reflexes. It's got good tone in both pelvic limbs, got good withdrawal reflexes, but has difficulty supporting that trunk. So that made me, I got T3, L3 spinal cord signs for the pelvic limbs, and I think it's more in the craniothoracic segments because of that difficulty supporting the trunk. And I've only got one differential as far as I'm concerned. This lamb was manhandled when it had its tail docked and vaccinated. And it got injured at that time. And to show you where the injury is, watch the deviation right there, and you can see that proliferation right there. That's the scarring that has occurred. That's the proliferation of bone trying to heal over the lesions occurring here. That's T3 and that's T4. This is 7, 1, 2, 3, 4. I got a fracture right there at 3, 4. And this has been, a couple of months? And that's just the healing that's occurred there. And that's just supportive of the injury that occurred prior to that. Charisma, 14-year-old female, Oldenburg, warm blood. Slowly progressive gait abnormality for several weeks. I think this is a T3L3 problem. I think those thoracic limbs are normal. This is a horse you really need your hands on, because when you're going to hold this horse, you know that back end can go either way, and if you turn this animal in a circle very fast, you're going to put this animal right down the ground. And you feel that, and I can't put that feeling up on the video. But those thoracic limbs are normal, as far as I was concerned, and you're looking at UMNGP system effect somewhere between T3 and L3. And we don't see this very often in the horse. And equine protozoal myelitis has to be the biggest concern, and don't rule out neoplasia. It certainly can occur. And when you look at the other end of this horse, there's your melanoma involving the vulva of this horse. They tried all sorts of vaccination procedures to try to help this horse, which didn't do any good. When I took this, I did the autopsy on the vertebral column in this horse, and I used a bandsaw to do a dorsal approach on the spinal cord. And as that bandsaw went through the muscle, there was melanin pigment going everywhere. This was all strewn out there. You can see that's all melanin pigment out here, and there's the mass lesion at T18 that was compressing the cord and producing the clinical signs. Okay, here's your challenge. I've gotten you this far. Now it's your ballpark. Brian Farrow, very close friend, spent many years at Cornell, but he's a Sydney University faculty member and very much interested in neurology. When he retired, he had a farm in which he tried to, I guess he was successful in making wine, but he rented out his pasture. And he looked out in the pasture one day, and here, for a guy interested in neurology, it was made. Here was this heifer walking around the pasture in a rather abnormal way. We know no history. All we know is that Farrow looked over the fence and said, I got to video that. Oh, hang on. Now you watch very carefully, because in a minute, this heifer is going to go down, or almost go down. And watch her as she tries to get back up. Here you go, watch. Oh, man. Now, I think those thoracic limbs are absolutely normal. You can see, what, short-strided. Yeah, it's short-strided because of the difficulty in staying up with the pelvic limbs as abnormal as they are. And those are certainly long, awkward, base-wide strides, typical of a UMN-GP problem. Now watch when she tries to get up. Question: is my lesion craniothoracic or caudalthoracic? It's craniothoracic. With that difficulty getting that trunk to function, that's a cranial thoracic spinal cord lesion. And God bless Brian. I don't know how he worked this, but somehow he was there when they put the heifer down. He got the vertebral column, and that's our anatomic diagnosis, and that would be a differential. But we have no history to help us deal with any of that. We sure don't have a CT or MRI in the pasture. And when he took out that vertebral column, he found a fracture of the body at T4, and he actually got histologic sections done on the bone to see whether there's any evidence of any bone neoplasia or discal spondylitis, and there was none. So why it fractured at the body of T4, we don't know. Maybe a mountain lion jumped on it. Have no idea. But that's a classical picture of a craniothoracic lesion. Furlong, 15-year-old female quarter horse. 12 hours before the exam you're going to see, sudden onset of wobbly pelvic limbs. This is on a Sunday afternoon. They noticed it suddenly. It was wobbly in the pelvic limbs. They brought her in the hospital, and I saw her early Monday morning. And I can tell you I'm not about to take this horse out of the stall, and I'm being very cautious in here, and you'll see why. I'm looking to keep that door in sight. This animal's cranial nerves are all normal. She was noticed to spill a little bit of urine. That's why her tail is bandaged up. As best I could tell, I didn't think there was anything wrong with thoracic limbs. But there sure was a problem with the pelvic limbs. And the signs in the pelvic limbs are T3, L3. A little hard to tell how far up in the thoracic region that lesion is. The tail, hypotonic. The anus was soft, not dilated and wide open, but soft and not as good a reflex as normal. Little less response to nociception than usual. But the lack of tone in the tail, lack of tone in the anus says something is bothering the sacrocaudal elements. So that's my anatomic diagnosis. And this to me is the classical presentation of a horse that's got equine herpes virus 1 meningeal arteritis. All the lesions I've ever looked at, I don't have a good explanation for the sacrocaudal signs that are seen in these horses, but they're quite typical. And a full bladder, some tendency to overflow. Equine protozoal myelitis would be there. Do we ever see fibrocartilatus emboli in the horse? Yes, but it's rare. I've seen it in a Belgian draft horse, and it would be an acute onset problem. But the equine herpes virus is an acute onset problem because it's a vascular problem. It's not an inflammation of the spinal cord, it's an inflammation of the vessels. It's a vasculitis. And these are sections from a horse that went down in 48 hours, right flat out. Hind end, front limb down, couldn't get in the sternal, and look at the hemorrhages scattered throughout that entire spinal cord. This is a picture of the normal anatomical distribution of blood vessels. Ventral spinal artery here, dorsal spinal artery there, a plexus on the surface of the cord, and notice the way the arteries radiate into the white matter, because I'll show you that's exactly the way the lesions will look. The arteritis occurs predominantly out in the meninges. You get a thrombosis of blood vessel, that's where your ischemia is going to occur. And that's what's very typical about this disorder. This is another horse, thoracolumbar signs like the one you just saw. And look up here, there's hemorrhage in an area of infarction, but see that little gray area right there? Keep that in mind. All right, see that little pale area right there? There's another one right here, but see that right there? I'm going to blow that up. Okay, here comes your blood vessel. That's the area it's supplying. And what you're seeing are spheroids, which are very typical of any ischemia to the parenchyma of that spinal cord, is to get myelin loss and swollen axons, spheroids. Where's the embarrassment to that blood vessel? It's out here in the meninges. Okay, and the primary target of that equine herpes virus 1 are the endothelial cells, and that's where immunocytochemistry will show you where the organs are located. Okay, 1-week-old Holstein heifer calf. Abnormal pelvic gait since birth, and this is not a diagnostic dilemma, but it's a good teaching case. At least this calf with its problem was able to walk. Oh, that's interesting. So as soon as you say that, oh, he's bunny hopping. I got a bunny hopping calf here. Or you might say, he's got simultaneous use of the two pelvic limbs. A little more academic. But what that tells you is that this calf has got a malformation of some sort in the spinal cord. It won't tell you what kind of malformation. Almost any malformation in the spinal cord that I've dissected at autopsy, they can have this simultaneous use of the pelvic limbs. It definitely is a marker of a myelodysplasia, unequivocally. And you can see there's a slight scoliosis of the vertebral column. You can palpate a slight vertebral abnormality there. And the combination of vertebral abnormality and neural tube abnormality is very common and is expected on the basis of the embryologic development. So you're looking at a myelodysplasia. That just says spinal cord malformation. Can be a segmental hypoplasia, a complete lack of a spinal cord area of development. Diplomyelia is two spinal cords within one meningeal container. Diastomatomyelia is you got two separate spinal cords separated by usually a bony partition. Any one of those can still be accompanied by the bunny hopping gait, and always palpate for vertebral malformation. What's the basis of the bunny hopping? I don't know. Okay? But it's certainly a disorder somewhere in the central pattern generators in the lumbosacral intumescence, involving the inhibitory. There's this crosstalk between, you turn on your flexors in this limb, I'm going to turn on the extensors in this limb. So you got to have inhibitory fibers going back and forth. And somewhere in that crosstalk, in the lumbosacral intumescence, is the basis for the bunny hopping gait. But you don't see it, you can't see that with a light microscope, but that's where it's happening. But here's the practical point. 2-day-old female Holstein, unable to stand the pelvic limbs. I was away from the hospital for a day, and this calf came in and was evaluated, and when I got in the next day, I was told that this calf is going to have a CT done today to see the nature of the fracture that it's suspected to have, because they could palpate a slight vertebral abnormality. Okay, and the surgeon had his instruments in his hand. And anytime I have a chance to twit a surgeon, oh, I love it. So I got the podium, folks. All I had to do was get this calf out once. Uh-oh. Now this calf needs help to get up. No question about that. And my immediate thought was, where's that surgeon? I mean, no spinal cord injury is ever going to produce a bunny hopping gait. This is an animal with a myelodysplasia to prove it otherwise. Now watch him flex both pelvic limbs. You check withdrawal in one, they're both going to go. The only reflex that stays asymmetric is a patellar reflex. It's a monosomatic reflex, and it was not affected by this. But any noxious stimulus is going to produce a flexor reflex in both pelvic limbs, just the way the calf tries to walk. And I happened to be in the room while they were doing the CT, and the surgeon was in the room. And as the vertebral canal got smaller and smaller, and the spinal cord got smaller and smaller, he left. Okay, I got another twit for the surgeons. Only this belongs to a surgical resident. 3-day-old female Holstein calf, dystocia, Since birth, unable to had no use of the left pelvic limb, not normal use of the left pelvic limb. And it came in on the surgery service, and they diagnosed a congenital left patella luxation. Now this calf can walk. He can generate protraction in the limb, but as soon as he puts weight on it, that left pelvic limb collapses. Absolutely no tone in that left pelvic limb. My right hand has got a hold of the patella. And sure, I can wobble it back and forth because the quadriceps muscle is denervated. You need a femoral nerve intact in order to support weight in the pelvic limbs. And this is a classical gait of an animal with a femoral nerve paralysis. Now, the femoral nerve has a sensory branch. It's the saphenous nerve. The autonomous zone is on the medial side of the crus, and that's what I'm going to grab a hold with the forceps when I get him calmed down. And that calf is not responding. So that means I got complete femoral nerve denervation, sensory as well as motor. Now watch the normal side. Back to the abnormal. Nothing. Now watch this. Don't stand behind him. That's the branches of the sciatic nerve. So this is a classical picture of a femoral nerve paralysis at birth in a calf, and this is a typical picture that results when an animal has had a dystocia, gets caught, he's getting pulled out by too many people this way, the hips get overextended, and as you overextend the hips, all right, you stretch that femoral nerve, which is coming out of the iliopsoas muscle and going right into the quadriceps and gets stretched out. I've necropsied one calf for this problem and actually found the roots pulled off the spinal cord. And so, you know, I don't have to tell you, you got to preach caution in the amount of stress you put on these calves at the time of dystocia. You can injure them in many ways. And just to complete the picture here, there we go. And there's Tom Divers eating lunch. And this calf is exactly the same history, only this is bilateral. A little worse left than right, but this calf is bilateral. About a year later, I pulled out the clinic records because I expected that first calf you just saw to end up necropsy in the afternoon. And didn't. So I followed up on it. About a year later, I got the owner on the phone. And she said, I said, whatever happened to that calf you brought to the corner? Oh, he says, down in the back 40. I said, did it recover? No, still doesn't use a limb, but we like her. That makes you happy. Anyway, sometimes they recover spontaneously, and this little calf did. Now, this calf did not have analgesia in the autonomous zone, so you knew it wasn't an absolutely complete rupture of that femoral nerve. All right, now, you've seen how an animal walks with a femoral nerve paralysis. Watch this. 12-year-old quarter horse, 3 weeks before the film, sudden onset of lameness in the left pelvic limb, no observed injury, and worse after 1 week. Now see, I got you all prepped for this. It's obvious to see that it can protract that left pelvic limb, goes to bear weight on it, and it collapses on him. But watch the right pelvic limb. That's affected as well. It's not as marked as the left one. But the gait in this horse is identical to the gait I just showed you in that little calf. And when you check the distribution of the femoral nerve in that left pelvic limb with a noxious stimulus to the medial side of the crus, this animal responds. But you certainly should be thinking we got a serious left femoral nerve problem and a less severe right femoral nerve problem. So our lesion can be anywhere from the spinal cord segments or out in both femoral nerves, and more likely it's going to be in the segments of spinal cord. Femoral nerves arise from the segments L4 to L6, and it's worse on the left side. This is absolutely typical of what a protozoal myelitis would do. And your other differentials are much, much, much less common in the horse. And that's an example of protozoal myelitis. And if you look particularly down here, ventral great column down here is all discolored there, and that's all inflammation associated with the protozoal agent. 4-year-old female Holstein, very unusual case here. 2 months before, it developed an abnormal gait, particularly in the left pelvic limb. And over the next 2 to 3 weeks, similar abnormality in the right pelvic limb. And the cow spends most of her time lying down now. And when you get this cow up, she obviously is favoring her right pelvic limb. Is able to use the tail. Showed no evidence of any loss of sensation or reflex, any innervation loss to the anus, vulva, perineal region. But watch the posture of the pelvic limbs. Notice the overflexion, lack of extension in the tarsus. And in particular, notice the fetlock region. Notice the way this cow buckles forward at the fetlock. That, folks, is an absolutely typical picture of a tibial nerve paralysis. I can readily explain the flexed posture at the hock because of the loss of extensors on the caudal aspect of the crus. I do not have a clear-cut explanation for why the cow buckles forward at the metatarsal phalangeal joint, but I can tell you that's absolutely textbook picture of this disorder in the cow. Now this has been progressive, and the left pelvic limb showed up before the right pelvic limb. You know, how can I injure the roots of the sciatic nerve? My obvious thought is fractured sacrum. Been ridden by a bull, ridden by an in-heat cow, and I got a fractured sacrum. Why weren't the signs sudden and onset? And why are my tail and anus working so well, as visualized there? I didn't have explanation for that. But Bill Revune did a rectal exam on this animal, and he said, you know, I don't like the feeling of the ventral aspect of that sacrum. It's just a little bit larger than it ought to be. Well, Bill was very astute. So I need an S1-2. That's the origin of the tibial component of the sciatic nerve. Spinal cord segment, roots of spinal nerve. Sacral injury has to be a consideration. Discal spondylitis could do this. The sacral injury is bothersome because why is it a chronic progressive problem? Okay, and other considerations, abscess, neoplasm, lymphoma. That's a longitudinal section. This is L6, and that's S1. That's the disc between L6 and the sacrum. That's a fracture through about the second sacral vertebra. And you can see the deviation of the vertebral canal. But that did not affect the nerves to the tail. Okay? Now, when I look at a dorsal view, I look at a midline section. There's your disc again. So this is S1 going out here, S2 going out there, and I had to carve those nerves out of those foramina in order to get the nerve out to study it. They were bound down in connective tissue there, chronic connective tissue, and that's what accounted for the chronicity of the signs. S1 came out here, S2 came out there, and S3 back there. And it's the fibrosis and compression that occurred to those nerves over time that accounted for the unusual history of the clinical signs. 2-year-old female Holstein, 1 or 2 cows with a similar pelvic limb gait abnormality that developed a few weeks after tail docking was performed, and these signs were progressive. Now, I'm not going to spend a lot of time in this video because you're essentially looking at it the same posture of that cow that I just showed you in the previous one. You've got the overflexed tarsi and a little tendency to buckle forward in the metatarsophalangeal region. There is lack of tone in the tail. There's lack of tone in the anus. There's some loss of sensation around there. So you got a nice example of sacrocaudal anatomic diagnosis. And the differential, discal spondylitis, vertebral canal abscess, neoplastic lymphoma. This cow will be old enough certainly to have a lymphoma in that area. You got the history of the tail docking. I have no idea what the incidence is of discal spondylitis related to tail docking, but sure as the dickens, that could have been the source of an infection that got in this animal. And this animal had profound discal spondylitis located at the L6-S1 junction. Okay. This goes back quite a while, but it's a classic example of making a neuroanatomic diagnosis. This is a 5-year-old gelded thoroughbred. Many weeks of multifocal muscle atrophy, left side of the head, right side of the pelvic region, the gluteal area, and 1 week of rapidly progressive pelvic limb paresis and ataxia, resulting in pelvic limb recumbency. And for you Cornellians in the group, I want you to watch very carefully at this individual that's going to show up right here, because that's Bill Rabune in the late 60s while he was still at Cornell, early in his faculty experience. In 77, he went and he brought Cornell to Penn. Okay, and that'll be Bill when we get going here. I'm not Bill Rabune. I'm sorry. That's Bob Whitlock. Sorry, folks. No wonder you didn't rise to the occasion. That's Bob Whitlock. Normal muscle mass on this side. Remarkable atrophy on that side, temporal as well as masseter. Pull the tongue out. I'll show you this better in a moment. The entire right side of that tongue is atrophied. Atrophy, right, left temporal, left masseter, right tongue. That's denervation atrophy. In the more recent rapidly progressive signs, it was the difficulty using the pelvic limbs, needed help to get up. I thought, as best I could tell, that the thoracic limbs were normal. Notice the use of the pelvic limbs and how short-strided they are. That says this horse, primary problem is he can't support weight. That has to make you think femoral nerve components can't support weight. And that's why he needs all this manpower, woman power, to pick him up. Look at the atrophy in the right gluteal muscles. I've been there for weeks. Minor atrophy in the caudal thigh muscles, little bit of atrophy in the caudal crural muscles. But severe atrophy up here, cranial gluteal nerve. The individual doing that pointing, you'll see in a moment with the longer hair, is Joe Mayhew. When Joe was a graduate student at Cornell. Long hair and all. We made a great pair. Little bit of loss and sensation around that area. But those short strides say major problem, can't support femoral nerve, L4-6 spinal cord segments. So, Anatomic diagnosis, it's all over the map. I got a left trigeminal nerve, mandibular nerve component problem. I got a right hypoglossal nerve, medulla problem. I got L4 to 6 spinal cord, that's the difficulty with the gait, and the L6S1 being cranial gluteal nerve. Tail, little lack of tone in the tail, and this could be segments of spinal cord, roots, or spinal nerves. Equine protozoal myelitis, encephalomyelitis has to be of major concern. It can occasionally just affect focal nuclei in the brainstem. I can't rule out polyneuritis equi. I've got signs in the lumbosacral area, and I've got some cranial nerve signs. I've never seen this kind of distribution with polyneuritis equi, but to me, that's the only other differential that I would have in this case. So I need to explain the atrophy that occurs in the distribution of the cranial gluteal nerve, and I need to explain why this animal is unable to get up in femoral distribution. Okay, look at a representative segment around L6S1. I'm going to take you into that area first and show you that's a chronic scar that accounts for the atrophy in the right gluteal muscles. And that is a very aggressive inflammatory lesion that has participated in putting this animal down with difficulty getting up. Okay, so we're going to come in that area first. Oops, too fast. Okay, watch this lesion right here. That should be all full of nice, big, healthy neuronal cell bodies. There's nobody home, nothing but blood vessels here, few inflammatory cells, and these are all astrocytes scattered through here. Reactive astrocytes, scarring it over. They've been there for weeks. They account for that atrophy that have been there for weeks. This is the acute, destructive, inflammatory lesion. Ventral gray column, L5-6, femoral nerve, going to be unable to support weight, higher power there. Many inflammatory cells through there, and occasionally eosinophile, and mostly mononuclear cells, and protozoal organisms. We have to explain the atrophy in the left masseter muscle, left temporal muscle. We want to look at the motor nucleus of 5. We're going to take a cross-section right through here, just in front of the middle cerebellar peduncle. That's going to give you the pons. And this is the normal nucleus in a dog brain at the same level. In this horse brain, look at that discoloration just in the motor nucleus of 5 on that side, and we'll blow that up. It's located right here, right there, and nobody's home. Those motor neurons have gone for a considerable period of time, and the atrophy in the left masseter muscle had been present for months. We got to explain the atrophy in that tongue muscle. So any cross-section back here at about the level of the obex should help us there. There's the atrophy we got to explain. And hypoglossal nucleus is located right here. You'll notice it is discolored on the right. The right hypoglossal nerve is a little discolored. There's the beginning of the central canal, just caudal to the fourth ventricle. Normal nucleus here, abnormal there. I'll show you the normal first. Nice, healthy, robust motor neurons in there. On the other side, nobody's home, just astrocytes scarring the area over. This has to make you, I've seen the same lesion in those nuclei associated with some inflammation in the adjacent parenchyma. But to get these nuclei burnt out like that, just like that, in a horse who has the organisms elsewhere, has to make you wonder whether those protozoal organisms, the Sarcocystis neurona, did they come from the muscle? Could they have come up through that mandibular nerve and just gone into their nucleus? That's an awful lot of muscles. I've looked at some sections of those muscles and never found anything, but there's a lot more muscles than I've got time to look at. Anyway, that's very provocative that might be a route of entrance of that organism into that area. A couple other things that involve neuromuscular elements. 17-year-old female standardbred, 10 years of age, had a fracture of its pelvis, right greater trochanter, and have an abnormal gait in the left pelvic limb that's been present for many years. I don't know when it was first observed relative to the injury, but I'm concerned that you see the gait in the left pelvic limb. Now, you haven't seen anything today that looks like that. This animal's neurologic function is absolutely normal. But when he protracts that left pelvic limb, it gets to a certain point and gets pulled back down to the ground surface. It can't reach the full stage of the end of its protraction. And this is because there's some fibrosis in the caudal thigh muscles, gracilis, semitendinosus most commonly affected. And if you think of shortening those muscles, when that stifle extends and it reaches that shorter end, it's going to pull the tibia back, and that's what pulls the hoof down to the ground. And you can palpate, my fingers are palpating a cord-like structure where the semitendinosus muscle would be located compared with the opposite side. So that's fibrosis of the caudal medial thigh muscles. And many people say, well, how do you know that's not string halt? There's no comparison between string halt and fibrosis of the caudal thigh muscles. And to prove it to you, I'll show you a horse that was donated to the hospital. And if you think that looks anything like what I just showed you, I quit. This is string halt. There are sort of two forms of string halt. The sporadic or classic form, which occurs in individual horses, sudden in onset, one limb or both limbs. There are absolutely no histologic lesions associated with it. Sometimes if you remove a piece of the tendon of insertion of the lateral digital extensor muscle, you can improve their gait. I believe some people have had some success using oral phenytoin with this disease. I have no experience with it. But this is an example of the classical form of the disease. The epidemic form occurs in Australia, western part of the United States, where there are plants, particularly the dandelion species of plants growing profusely in the pasture. Horses have to be on it for quite a long period of time. They're usually bilaterally affected, many horses at once. If you get them off early, they can recover. If you don't, they're there for a while. They're going to be permanent, and they have an axonopathy that can be demonstrated, particularly in the distal components of the branches of the sciatic nerve. But that is what string halt looks like. So the anatomic diagnosis is this is hyperactivity of the flexors of all the joints of that pelvic limb. In the animal with no lesions, to me, this is a disorder in the central pattern generators in the lumbosacral intermesic. It could be in any part of that innervation, but I think that's probably where it is, something you cannot see with a microscope. I got to back off here. How long has string halt been around? Well, Brian Farrow in Australia, I think actually his wife dug this out, but that's all right. She's a veterinarian too. In Shakespeare's Henry VIII, there's a description there of the horses that says the spavin or spring halt among them. And we think that spring halt was translated to string halt, and that's where it came from. What it means is it's been around one hell of a long time. Okay, and it's just summarized here what I just told you about the sporadic form and versus the epidemic form. And just to prove to you, I'm going to erase it, that the epidemic form does exist. Note the atrophy in the crural muscles. And that's because this animal has a neurogenic problem. This animal has an axonopathy, a distal axonopathy in the branches of the tibial nerve, probably some of the perineal as well. And this animal's been on a pasture where dandelions are abundant. And this is the epidemic form of this particular disorder. One more problem that involves a gait disorder, and this is the pelvic limbs of a 5-month-old female Holstein. Progressive gait abnormality with the left pelvic limb for about a month. There's a classic for you. Every time that animal goes to try to advance the limb, it goes into extension. All joints, hip, stifle, hock, and like the horse or string hoe, part of that action you see is related to the reciprocal apparatus that it has in the pelvic limb. And the ruminant has the same thing. But this is a functional disorder. There are no lesions associated with this. And it's progressive. And it's referred to, I don't know, I can't take credit for the name because it's terrible, but it's called spastic paresis. But it's a hyperextension phenomenon in the calf. It also has, if you ask Dr. Francis Fox at Cornell about this disease, he says, oh, that's Elso heel. Who's Elso? Elso is an old bull from the Scandinavian countries that seeded this down all over Eastern Europe, Western Europe. It's seen quite commonly in this country, I think, in Angus cattle, and sporadically in any of our dairy cattle. If this is a common occurrence in a farm, there are surgical procedures for cutting various components of the common calcanean tendon, the insertion of the gastrocnemius muscles on the tubercalcis, some denervation, some of it advocating cutting tibial nerve branches, just so that they can get around better, eat better, and get them to market age. You want to castrate them at the same time. So this is spastic paresis or Elso heel. It's a form of inherited tetany. I use the term tetany because by definition that means a constant contraction of extensive muscles that's intermittent. Tetanus is constant contraction of extension muscles that is continuous. Well, this is not continuous. He lies down and goes away. If he's standing quietly, it eases off. As soon as he moves the limb, it occurs. So this is tetany by definition. There are no gross or microscopic lesions, and some really kind of unique studies have been done many years ago on trying various ways of interfering with the neuromuscular spindle reflex arc to see if they could precipitate this problem or terminate the problem. And they found that if they used very dilute lidocaine epidurally, you can block gamma efferents without blocking alpha motor neuron efferents. Okay? So this will block the gamma efferents. You take the gamma efferents away, they're responsible for stretching the spindle, 1A afferent, stimulated alpha motor neuron, extensor muscles. So you've disinhibited the extensor muscles. So this appears to be a neurophysiological problem at the level of the gamma efferent motor neurons in the lumbosacral interferent, in the mesoid. Now, it's been a long time since I read that data. You people are much more current than I am, but I have not ever read any further explanation for the particular problem. And I think that's a good time to cease. Thank you very much for your attendance and interest.